Cast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to today's presentation, which is part of a series of webinars provided by the Division of Public Health, Section of Chronic Disease Prevention and Health Promotion. Our work focuses on chronic disease and injury prevention, as well as data collection and surveillance. This webinar series was created to provide a way for us to talk about our projects and explore how we can work together. We will be offering webinars on the third Tuesday of every other month at 1 p.m. There are a few housekeeping items to go over before we start. If you are listening by phone, please keep it on mute. Please do not put this call on hold. If you receive a call, please hang up and call back in. The webinar is planned for 30 minutes, a 20-minute presentation followed by 10 minutes of questions and answers. A recording of today's webinar will be sent to all participants, and the slides will be made available online soon. Audio will be coming through your computer. You also can call the number provided. If you need help listening to or watching this webinar, please let us know. To ask a question, you will need a microphone or you will need to call into the number provided. Please hold questions until the end of the presentation. We will now start today's webinar.
Good afternoon, and thank you for joining today's webinar. My name is Andrea Finotti, and I'm a chronic disease epidemiologist here at the Section of Chronic Disease Prevention and Health Promotion, and also the evaluator for the 1305 grant. I will be describing some of the evaluation results from year 4 of our 5-year 1305 grant from the Centers for Disease Control and Prevention, the longer name of which is State Public Health Actions to Prevent and Control Diabetes, Heart Disease, Obesity, and Associated Risk Factors and Promote School Health. I'm going to start off by giving you a high-level description of the grant, then say a little about the kinds of activities we've been working on. I'll touch very briefly on how we did our evaluation, then I'll get to the meat of the presentation, the main findings. Finally, I'll wrap up with some cross-cutting themes we saw across the various components of the grant and tell you about our next steps. CDC recognized that many chronic diseases like heart disease, stroke, diabetes, and cancer often happen to the same people as a result of common risk factors. For a number of years, CDC has been trying to encourage states to work in a more integrated way across our programs so we can be more effective at addressing chronic disease in general. Of course, one of the main reasons we often worked within our programmatic silos was because our funding from CDC was itself siloed. So a diabetes grant to address diabetes, but a separate obesity grant to address obesity, which is, of course, a big risk factor for diabetes. The 1305 grant was one of CDC's strongest statements yet that they would put their money where their mouth was and actually fund states in a way that would truly support integrated work. There was a 5-year non-competitive grant that went to all states, then some supplemental funding that followed a year later. The program areas that the grant addresses are school health, obesity, heart disease and stroke, and diabetes. CDC developed a 4-domain framework of how chronic disease prevention work should be done. For this grant, states needed to employ strategies that span these 4 domains. And they are epidemiology, surveillance, and evaluation to inform, prioritize, and monitor diseases and risk factors and the delivery of interventions. Environmental strategies that reinforce healthful behaviors and expand access to healthy choices. Health systems interventions to improve the delivery and use of clinical and other preventive services, and clinical and community linkages to better support chronic disease self-management. So that's the general approach of the 1305 grant. Now let's look at the different kinds of strategies we've been implementing. First, we'll look at school health and obesity prevention strategies, all of which fall under CDC's Domain 2, because they focus on changing either the physical activity environment or the nutrition environment across a variety of settings. You can see the settings listed here are early care and education, or daycare settings for the under 5 population, the K through 12 or school age setting, and work sites for adults. Whatever the setting, we are working on improving environment so that the healthy choice is the easy choice. For the purpose of this grant, CDC refers to those strategies occurring in the school setting as school health strategies, but you can see they really all are obesity prevention strategies. So just to pull those apart, in the K-12 school setting, we are promoting the adoption of food service guidelines and creating supportive nutrition environments, and also promoting the adoption of physical activity and physical education policies and practices. In ECE and worksite settings, we are also promoting the adoption and implementation of food service guidelines, as well as the adoption of physical activity policies and practices. For the health systems component of the grant, one of the main focus areas has been to promote reporting of blood pressure and A1C measures within health systems. The second focus within this component has been to use a quality improvement approach to improve the treatment and management of hypertension and diabetes within one health system, federally qualified health centers. Finally, we are working with the help of the Alaska Pharmacists Association with pharmacists around the state so they are better trained and prepared to manage patients with hypertension and diabetes. Within this final component of the grant, we have focused on these strategies. First, increase awareness of high blood pressure and prediabetes. Second, promote appropriate evidence-based self-management of diabetes and prediabetes. Diabetes self-management education targets reducing complications from diabetes among those with diabetes, and the diabetes prevention program aims at keeping those with prediabetes from progressing to diabetes. It's important, of course, to evaluate these various strategies to see if we're making the desired impact and to be able to adjust our efforts as needed along the course of the grant. Here are the basics on that. For each year of the grant, we develop an evaluation plan that includes both process and outcome components. Those plans focus on specific evaluation questions and not the entire set of strategies we are implementing that year. The data for the evaluation come from a number of sources, including those identified as part of our performance measure tracking, key informant interviews with staff who implement the strategies, an annual survey that partners and staff complete, and additional domain-specific surveys, logs, or other reports. The qualitative and quantitative data are synthesized and findings are reported in an annual evaluation report that we send to CDC. Given the time allowed today, I'll be skipping over the process evaluation components of the evaluation and just highlight a few key elements of the outcome evaluation that was done in each component of the grant. For the obesity prevention efforts, we focused our evaluation on implementation of healthier nutrition policies within the early care and education setting. Evaluated strategies included our partnerships with Alaska's Child Care Resource and Referral Agency, THREAD, and Rural CAP Head Start to provide some intensive trainings around adopting national nutrition best practices, and our facilitation of the ECE work group of the Alaska Alliance for Healthy Kids, as they addressed how to improve nutrition and food service standards and Alaska's child care licensing statutes and regulations. The main outputs related to the quality initiative were that 17 early care and education sites completed the THREAD quality initiative in year 4. An additional 22 Head Start sites also participated in a similar quality initiative developed in partnership with Rural CAP. Since the initiation of the QI programs, a cumulative total of 51 ECEs have adopted nutrition standards for their sites, impacting nearly 1,400 children in those ECEs. Examples of these nutrition standards include limiting 100% fruit juice to no more than 4 to 6 ounces per day per child, and serving fried and pre-fried potatoes, meats, or fish no more than once a month. As for the Alaska Alliance for Healthy Kids ECE work group, they were instrumental in moving forward to the Child Care Program Office a proposed set of licensing changes to better meet national obesity-related standards. Examples of these changes include fruit juice shall not be served to children younger than 12 months, and providers shall eat only food that meets the child care food program requirements when eating in the presence of children. A number of factors were identified as having contributed to success in this component. The fact that there was evidence-based guidance around developing policy on what children should eat in early care settings, the use of experienced local trainers as part of the QI program, and the fact that a new set of block grant requirements coincided with the work of the work group. This meant that the CCPO, which licenses ECEs and participates as a member of the ECE work group, included nutrition and physical activity as a mandatory training rather than an optional training for ECE providers. And because of the new block grant training requirements have to be approved through the licensing change process to meet a new federal deadline, the proposed changes that the work group submitted were bundled with the block grant changes and are now moving through the process sooner than expected. Barriers to this work included the fact that the kind of intensive TA that was provided to ECEs is expensive, and the reach through thread was limited. To address this, we expanded the QI program to Head Starts and are looking into online options. Another barrier is simply that policy and regulation change is slow and not fully under our control. We worked within our scope, though, by providing science-based recommendations and rationale to those who can move the proposals forward. Now, switching to evaluation of the school health efforts in this grant. The evaluation focused on these two sets of activities, both of which supported the objective of having better nutrition environments in school settings in Alaska. The first was about providing professional development to school staff broadly across the state in support of improving nutrition environments. The second was providing more intensive technical assistance to select school districts to help them improve their nutrition environments. The key activities and outputs for this component were promoting the gold standard wellness policy, which addresses physical activity, PE, and nutrition in the school setting, sharing successes broadly when school districts made improvements in their policies, presenting information on improving school-based nutrition for 18 different audiences, equaling over 300 school staff, and providing that very intensive technical assistance to 3 school districts across the state. In year 4, 2 of those 3 districts had improved their wellness policies. Facilitators in this area included the following. We had funding outside of the CDC grant to fund a coordinator on the ground at each of the 3 school districts we worked with in that more targeted fashion, without having a local coordinator whose job it is, day in and day out, to focus on improving the physical activity and nutrition environment at a school district level. We would likely not have seen the kinds of policy improvements we witnessed. The USDA final ruling that came out in 2016 was helpful in a number of ways. It was a newsworthy event that brought awareness to the issue of local wellness policies. It came with a compliance deadline, which helped create a sense of urgency around making these important changes. And it served to re-engage some of our key partners in the process, such as the Association of Alaska School Boards and the Department of Education and Early Development. Another facilitator was the passage of Senate Bill 200 in Alaska, which became the Physical Activity in Schools Law. By requiring school districts to establish guidelines to provide opportunities for 54 minutes of physical activity each full school day for students in grades K through 8, this law motivated schools to focus on local wellness policies. Finally, the School Health and Wellness Institute, or SHWE, now in its 13th year, is a well-known and respected venue for school health-related professional development. It allows us to efficiently reach school staff statewide with information on evidence-based approaches. Challenges included the fact that our targeted TA was limited by funding. One way to try to mitigate this was to share the successes of the districts we're able to work with broadly, to serve as a realistic example of what districts can achieve and how they did so. Turnover within school district leadership always has the potential to slow down progress when that school public health partnership is so essential, and that happened this year. Also, our partners at the Department of Education and Early Development have a lot on their plates, and their focus is on academic success, not necessarily health. We lost a longtime champion of school health to retirement recently, but they were able to hire new staff, and we look forward to working with our new partners. Now moving on to the component of the grant that focused on health system changes. Specifically, we evaluated our efforts to increase the use of pharmacists to support self-management of high blood pressure and diabetes. We accomplished this through providing a series of trainings for pharmacists aimed at increasing their use of medication therapy management, support of lifestyle interventions to reduce risk of complications, and taking blood glucose and blood pressure measurement, and also helping patients interpret those results. So 5 different trainings were provided covering those topics to a total of 268 pharmacists and pharmacist techs. 71 to 94% of attendees strongly agreed that the trainings increased their knowledge of new diabetes therapies, pharmacy-based cardiovascular disease risk management, pumping insulin, heart failure, and improving outcomes in persons with diabetes. In addition, we supported workforce development for pharmacists by supporting a partnership between UAA and the University of Idaho that led to the inclusion of 2 programs within the new American Pharmacists Association Academy of Student Pharmacists, Operation Diabetes and Operation Heart. These programs provide student pharmacists with information on medication therapy management and lifestyle change programs. The big facilitator of all this professional development was the partnership with Alaska Pharmacists Association. They provided a mechanism for connecting with pharmacists, helped facilitate the trainings, and also made connections with UAA for that workforce development piece. Barriers we experienced included that our reach was limited to the member pharmacists, that pharmacists don't necessarily have the freedom or capacity to perform MTM, and that billing for MTM has not yet been solved. Our final grant component is what CDC refers to as community clinical linkages, which for us was increasing the use of lifestyle interventions to reduce risk and complications of diabetes. For the evaluation, we focused on increasing awareness of the Diabetes Prevention Program, which is an evidence-based program that can prevent the transition from prediabetes to diabetes through lifestyle changes. To increase this awareness, we placed a number of ads statewide encouraging people to take the prediabetes risk test, provided resources related to the DPP on our website, and published articles describing successes with DPP. We also provided the online DPP called Turnaround Health for free. In year 4, 6 sites in Alaska offered the DPP, and then there was also the online version. A total of 254 Alaskans participated in the DPP through June of 2017. One of the biggest facilitators of success this year was the partnership with Nutrition Quest that led to our ability to offer the online DPP, Turnaround Health. Other promotional venues and resources, such as our public information team, the many web-based dissemination channels, and the existence of a periodical like the Senior Voice that reaches so many people, were also critical in getting the word out. Lack of coverage for DPP was definitely a barrier we heard over and over. The good news, Medicare coverage is set to begin in 2018, and we're working on a project with the Medicaid program that we hope will pave the way for future coverage there as well. The DPP is challenging to provide in many areas of Alaska. This is why the online option was so exciting to add, and we will soon be testing a new telephonic option. Looking at the results in their entirety, there were a few themes that cut across the different components of this grant in terms of outcomes, facilitators, and challenges. First, as far as outcomes, we saw progress in terms of healthy policies either adopted or improved across a few different settings. This is important, as we know that improving policy is one of the most sustainable approaches we have of improving the health of the population. Part of the reason we had success in changing policy was because we invest so much time and energy into building the capacity of partners in a variety of settings via professional development. Turning to common facilitators we saw, one obvious one was our extensive use of partnerships to extend and enhance the reach of what we're able to do. Our partners often have the skills, the relationships, and the flexibility to perform aspects of chronic disease prevention that we ourselves cannot. For the 1305, our partners helped promote our resources, facilitated the engagement of additional partners in the collection of important information, and overall helped to energize our initiatives. Multiple 1305 efforts also benefited from policies at the state or federal level that provided clear guidance on implementation, drew attention to an important issue, or otherwise motivated partners to implement evidence-based strategies. Finally, we did experience some common challenges across the different components of the grant. One was that, given Alaska's size, limited road system, and lack of local public health infrastructure, it is very expensive to provide the kinds of intensive technical assistance that is often needed to promote the environmental and systems changes we're trying to effect. Also, forces outside our control, such as what payers cover or how certain types of services are billed, have a huge impact on the success of our efforts in the health systems change area. It's not that we don't have any role in making some of those systems changes, but it's often not a very direct one. So in the coming weeks and months, we will continue to share these results with our evaluation stakeholders using methods such as this webinar, as well as a variety of stakeholder-specific reports and outlets. As for the 1305, we are currently in year 5 of this 5-year grant, so we'll be wrapping things up at the end of June. CDC has asked for more brief, summary types of reports called health impact statements at the conclusion of the grant, so stay tuned to hear more about those. CDC has split up the 4 components of the 1305 into 3 for the next round of funding, and so we're already planning for responding to those funding opportunities. Please feel free to reach out to any of the folks on this last slide if you are interested in hearing more about that this spring. Thank you for your time and attention, and now we'll open it up for questions.
So anybody who'd like to ask some questions can feel free to raise their hand to let us know, or else type them in and we can answer those for you. As we're waiting for those to come in, just a reminder that the webinar will be posted as a PowerPoint and a video presentation on our section website in the coming week, and we will send out an announcement to those who've registered to know how to find it. It doesn't look like there's any questions in here. This last slide does have email addresses for a lot of the programmatic leads that can address questions should they come up in the future. So please feel free to reach out to any of us to answer some of your questions. We'll hold the line for a little bit longer and then we'll end today's webinar. All right, thank you so much for your time today, and we'll be posting this soon for you to review again. And look forward to you participating in our future webinars. Thank you.